Hello, and welcome to another Spotlight the Science, where we get to meet the researchers who receive research funding from the American Diabetes Association. So my name is Marlon Pragnell, and I'm the VP of Research and Science at the ADA. And today we're talking with Dr. Louise Reagan. Dr. Reagan is an assistant professor at the School of Nursing at the University of Connecticut, and she received her PhD at the University of Connecticut and her postdoctoral research training at New York University. And she's working with some incredibly interesting populations. Her research focuses on health disparities in incarcerated environments. And it's a great pleasure to see her again. We actually interacted. She came and presented beautifully at our health disparities workshop in Washington, D.C. last year, and it's great to see you again. Welcome.
Thank you, Dr. Pragnell. Thank you for inviting me, and thank you for the opportunity to be here. And I just want to say thank you to the ADA for the funding and to be able to support my work. I really appreciate it.
Great. So it's quite shocking, and I'm reading some of your work that the there the there's a significant amount of diabetes in prisons. I mean, I think that's like 50% more than in the general population, correct?
Yes, and so that's if you think about it, if you look at the population that is in prison, if you match the samples to age, race, and Hispanic ethnicity, then yes, the incidence of diabetes rises drastically. So our population that's in prison and that's getting out of prison mirrors the population of people that are in the United States that also are affected by an undue burden of health disparities.
It must be very difficult to manage diabetes in an incarcerated setting, with an environment so different from home, and also too, these are obviously people who are challenged because of being, having gone through the justice system, legal system, and so on. How do people manage their? I mean, a person with type 2 diabetes or type 1 diabetes, how would you manage that in a prison environment?
So in the United States, there are a lot of constraints on self care in the prison. It's quite different actually. If you look at international, I do present internationally, and when I go there and present, they kind of scratch their heads. They don't really get it because in the United States, for instance, not the men and women that have diabetes, they don't have access to if they're insulin, they don't have access to insulin to administer their own insulin. They do have access to some of their medications, their oral medications. So people, what we call keep on person, where they're actually given medications. And so they can self-manage in a little bit in that way in terms of deciding, when to take their medications. But, they can't just keep their medications. They have to make sure they take them because if they don't, they get taken away from them. In terms of monitoring their blood glucose, that's challenging as well. There's been some work in some states where they've done studies to actually give people a meter in these settings, but it's not everywhere. So in many of the settings, the people with diabetes that are living in these facilities are going to a medication line or a sort of a window where they would check their blood glucose, maybe have a place to write it down. Maybe it gets written down, by the nurses, and then or whoever's delivering giving that medication, and then they get their insulin. So that was the problem I saw when I started working with this population and collaborating with, the Department of Correction and people that really have a vested interest in trying to make diabetes better, were some of the constraints on self-care and trying to figure out, what if someone was diagnosed in prison and then they get out? They really don't have a chance to, they don't really have a chance to practice a lot in prison. So that is a big challenge, is the insulin administration, the blood glucose monitoring, which are big components of people's care for diabetes. Trying to think in terms of food, there's a standard food menu. It's not, some states have what's called a special diet where they may substitute things for, to make it more appropriate for a person with diabetes. They have commissaries where people can buy food, and they may have some things there that may be more that better suited for people with diabetes, but the foods are pretty much standard, and it's not going to be the greatest in terms of what they have available. Additionally, you have to figure that people that are in prison, even though you have access to different foods and commissaries and things like that, you have to have money to pay for that. So I found it interesting that there's actually disparity within, in the facilities, because if you don't have money, you really don't have access to buy something different or, try some food from the commissary.
Interesting. Yeah. And I think I understand that from your writings that like 1/3 of people, 1/3 of the people with diabetes in prison find out they have that for the first time that they're in prison. So this is a new thing for them, right? To experience this.
Yes. And there is different, when you talk about prison, there is in terms of federal versus state, so there is different care in these facilities. I've seen that when I've had students that were in the federal, and then my own work in the state prisons. So there's just a lot of, it's not, when you talk about people that are coming out of facilities, it's different from state to state. It's different from federal to state. So there's a lot of work on all levels.
So when a person is in prison, say for somebody's incarcerated, and they find out they have diabetes, what's next for them? How do they learn about how to care? How do they learn? How do you educate them in terms of diabetes self-care?
Right. Well, and again, it's going to be different depending on where you are, but that one of the things that I when I started being involved with this population and with the Department of Correction, is that I observed they really are trying, at least in people that I work with, to meet the needs of people that are in prison. But there's a lot of people with diabetes and other health problems, so there's a lot of work. But one of the things that I first came into was observing a group medical appointment, and it was a modified version of what we do in the community, where you provide medical care. They had a nurse practitioner providing medical care, and then they had the groups that would come in, and then after the medical care, they would sit and they would either have a speaker or have some sort of discussion about a topic. So I observed that. They asked me to observe that, and the issue was that some of the materials, were not maybe literacy appropriate. The topics were not really individualized in terms of there was people with different racial and ethnic backgrounds there. Maybe people that didn't understand, English wasn't their first language. So when I spoke with people after that and did some interviews with people that attended that, they still had a lot of beliefs and some myths about diabetes. That in terms of, this only affects me here. When I get out, it's not going to be a problem. So even after attending this group medical appointment, and for quite a long time, there was still a lot of areas that need improvement. So that's why I started working with the Department of Correction in terms of trying to figure out how to better provide education for these patients. Because the nurses, they usually see people during the medication line, but there's not a lot of time for education. People are supposed to see someone before they get out, a social worker, a nurse, discharge planner, who hopefully has been able to give people some education they need. But if it's a quick decision to move someone from inside to, say, like a facility, a supervised community setting, or even like to go home on parole, that's a lot if you haven't really started sort of the education process. One of the things that I found in one of my studies when I did the diabetes survival skills inside, and we actually were in person with people, is that there's a lot of discussion amongst the people with diabetes. They talk to each other. So, they even use the term block doc, you know what I mean, in terms of, because they have people that they had it for a long time, so they would try to help them. But, that's not always the best way either, because then there's still things that get perpetuated that maybe are not actually the best ways to take care of your diabetes. So I think that in terms of when people get diagnosed, it depends. They have, a lot of facilities have chronic care clinics, so they see people on a regular basis. But it's hard to get in the community for this sort of education. So it's even doubly hard when you're in prison. And in terms of having self-management education available, I would probably say that most facilities don't have access to that sort of diabetes education, on a regular basis.
Well, but it seems like that's such an opportunity. You have people a person in an incarcerated situation. You can reach them. There's opportunities to educate them, and how are you approaching this in your work and your research?
So how I started is that obviously I believe in engaging the people that are going to be involved in any education. So the people that have diabetes and that were either had exposure to the criminal legal system or that were in actually incarcerated. So my dissertation work involved, after I did the work on the medical appointment, my dissertation work involved really doing some quantitative, testing and surveys with about 125 people that were incarcerated in different facilities, both men and women, and I asked them about, their beliefs, their knowledge, their self-care, and then using that information, I started to build things that I noted that were, should be components of what they needed. Also talking with your stakeholders, in terms of people that are working with this population, in terms of what they see and trying to manage the diabetes. Additionally, I did some work where I did qualitative study where I talked to people that had been in prison and were out, either in the community or so they had a history of incarceration, or they were serving like an end of sentence, doing in the supervised community housing facilities. And I did a qualitative study asking them about the barriers and facilitators. I kind of came at it from a, information, motivation, and behavior in terms of asking, those questions in terms, and then also really brought in their individualized experience of what it was like to have diabetes in prison and what it was like when they got out. So using that information, I found that they, they had information about diabetes, but again, the big problem was is that a lot of them thought, once I get out of there, I'm going to not have it when I get out, and they still had that belief when they got out. And there was a lot of questions about not even knowing what type of diabetes they had. Do I have type 1? Do I have type 2? And people assume that because they were on insulin, they had type 1. Not really understand, having some of the beliefs around the medications, particularly insulin. Sometimes it does have a negative, people even in the community have some certain beliefs around insulin, but it was even stronger around the people that I saw. And then there was also, it was that they had difficulty, reading some of the stuff that people would give them in terms of, was it really meant for them? And was it really in a format that was going to help them to really sort of understand the material? So I learned that between all the research that I did that showed how when they came out, they're trying to re-enter in society. They're trying to socialize with lost connections. They're trying to seek employment. That's a big thing. Now I saw some people, were still trying to get their IDs, so you couldn't really do anything. Access to medical care. Now, and again, it's different by state, but, I'm fortunate that we have a state where, that people can get hooked, into a system. So they'll have an appointment when they get out, but still there's that transition period, that period of, that's really chaotic, that where I saw the need when I interviewed people on the outside that we need to help some people with the people that are going through the transition. So my initial thought was to do this before they got out, right? To start a program built upon what I had observed in the group medical appointment, what I had heard from the participants themselves who have a lived experience of incarceration and diabetes, and the work that I had done for my dissertation, to build upon that and to do a pilot program inside prior to 6 to 9 months before they were transitioning out. And it would be a pilot of 6 sessions. And what I found out is that it was really about the diabetes survival skills, really trying to help them, sick day management, getting their medications, knowing that they're going from an area where they didn't have to do a lot, and now they're going to have to do much more in terms of taking care of their diabetes. So thinking about all that, we had the 6 sessions, and I used materials from the Partnership to Improve Diabetes Education, the PRIDE study, Dr. Rothberg, and he let me use those, and we used diabetes prompt packs, so conversation starters about diabetes that were developed by at the time, the AADE, the Association of Diabetes Educators, and they allowed me to adapt those for my population. So I built this program on information that was given to me, the research that I learned from the people that were, have diabetes and living in these areas, and also transitioning out. And we delivered that as a 6-week intervention. And it was well received in terms of people came, they loved it. We had more, we were better as far as recruiting men than women. We had, I'm sorry, this study was just with the men. I had done work with the women when I was doing some qualitative work. But what we found was that even though we were identifying people that were within 6 to 9 months of transition, that because it just was not predictable always as to, so people came into the program and they would tell me, oh, I'm going to be here for the next 6 weeks or 9 or 6 months, that big period. But what had happened is that they might go to a trial, or they might have some sort of a release option, and then they were gone. So we had a lot of attrition, or we lost a lot of people in that in-person setting where we were doing it. I was going into the facilities, doing the classes in person, and working with groups of like 12 people, that would come. But it was probably, I averaged around 6 to 8 that showed up for the classes. And they were, like I said, interactive. And then we also, being in person, we were able to do skills demonstrations and things like that, which they really liked. So, but because of the high attrition, so we had 98 people in the study. It was a feasibility study. It was funded by the American Nurses Association. We lost a lot of people because they would get out. And so I would have them, they would call me when they were in their, either in a supervised facilities or at home, because part of the agreement for me to do the research was that I had to provide that education anyway, even if they got out. So I would get calls from them, and I would have to meet them, at the facilities, or I would even get calls from them about help that they needed in terms of, like, they knew that there was something wrong. Maybe they got a medication that the concentration of insulin was higher than what they were used to. And so how are they going to get this dose that they needed? So I would get these calls from people that would tell me, I need help. So what we learned from this whole problem is that, from that research, is that we needed to probably move to the outside, be ready when people came out into the facilities or at home to catch them just in time, which is the reason why we named the next study Diabetes Live, just in time for community reentry. So that pretty much is how I ended up getting out into the virtual arena from the in-person. But also, I must say, COVID, right? COVID came, and that was a big, so we had to figure out how to get access into people, because a lot of the facilities shut down, a lot of the, understandably so, with all the COVID and the infection. They were hit very hard. So it was hard to get access to people and to deliver this education.
So then, just in time, so then this is a virtual offering, then you deliver it virtually, and so people will get this education, and as they transition to the community, back to the community, then they have the support system, this educational tools and so on, to adapt to this new, to living with diabetes in the external environment after coming from a incarcerated situation.
Yes.
And so how are you seeing it then? Are you seeing benefits there? Are people, I know this is still a work in progress, but are you seeing
Mhm.
benefits with people kind of getting this education and then moving into the community?
Uh, I mean, I think that so we have people coming to the classes, and some, and I think I'll just go back a little bit in terms of I've had experience working, how my work came to this point. I should mention also is that, working as my postdoc at NYU with my mentors there, who were PIs on an HLBI grant that was testing the efficacy of a virtual environment in a community dwelling setting using a PC-based program. And so, because my background was as a nurse practitioner, I was interested in self care, particularly diabetes self care. So it was an ideal situation for me to do my postdoc at the start and be the project site director for the NYU site, and then working with my the PIs that were from Duke, who developed this testing this virtual environment on a PC. And so what happened is that I was doing my work with people that were incarcerated or with a history of incarceration, sort of in parallel to what I was doing for my postdoc. So and it was different, right? It wasn't using the virtual environment. I think what happened but I learned a lot from helping, being the project director on that site, and also developing questions for that virtual environment, writing a publication, an article about the virtual environment. I learned a lot about it. And when we had the problem with the attrition and losing people from getting out before they were finishing the diabetes sessions, and then COVID, limiting our access to patients, I started to think, well, I wonder if we could use the virtual environment, and I could use my program, the diabetes survival skills, adapted to the population that I was working with, and sort of meld those together. So that's when I started working with my colleagues, Dr. Um, uh, Constance Johnson and Allison Borderstrass, who at the time were at Duke, and now are at UMass and UT Health, and Dr. Malkus, who was my mentor at NYU, and started to really think about this could really work. But we had problems with in terms of people don't have access, especially the population I work with, they don't have access to computers, that function like people that have jobs that need those type of things. So it had to be mobile. I just knew it had to be mobile. My experience with the population, and again, different by state, is that they really try to get people that are getting out into the community. They try to get them connected with a phone of some sort, because it's right nowadays you need a phone to be able to do anything, get your job, your scheduling, phone calling, all of that. So I knew that they had mobile phones in some capacity. I just wasn't sure about how good what sort of phones they had. So that's when I started talking to my colleagues and developing this idea to present to the ADA that blended this virtual environment with the my program of the diabetes survival skills. And it's been really exciting because that's what we've been doing for the past couple of years, developing the app and working with patients and people, participants that are coming in. And right now what we're seeing is that they are coming in, they're quiet, but there are some that will ask questions. Like, for instance, I'll give you an example. We have classes on right now on Sunday and Wednesday at 6:30 at night, because people work, people have jobs. So we try to work around their schedule, and we ask them when they would like to have the classes held. So we open the class on the app. They come in as their avatar. The nice part is they get to be anonymous. They don't have to show their face. And there is a stigma when people come. They don't want to be associated with a group of people. They want to leave behind what they just came from as quick as possible. So we try to make it where people can be anonymous. We hear their voices. We give them different names, and they have their avatar that they can create. But during one of the sessions, we were talking about medications, and I'm sorry, we're talking about monitoring. And so one of the gentlemen, raised his hand, and he asked. He said, I've never really tested my blood sugar after eating. Is that?" And how it came up is because we were talking about some of the medications that work, better, that help with some of the high blood glucose after eating. And so just things like that, they've never really had anybody really talk to them about. It's not just about checking your blood glucose, it's about checking it when you need to check it and knowing that you want to do something with it. So I feel like that we've gotten, that sort of, they're involving in that interaction. Another example is somebody contacted me. We have a study-based phone. We also use Google Voice and things like that to communicate with people. They were having a problem. We have on the app questions that they can answer. It's sort of a play function. So it's sort of like you go in, we have adapted the questions to a by literacy level, and they're all about diabetes, lifestyle, cardiovascular, a lot of different things. It could be about anything. And they go in and they get a certain number of questions a day. I think even like 25 questions a day. And they can answer those questions and they'll get a great job, that was great, or, try again. And then sometimes there's a little, if they get it, when they get it right, it's like, good job, and gives a little tip about something related question. But I had someone contact me and say, the question got stuck or something like that. I answered it correctly. I checked the answer on the internet or something like that, and I know I have it right, but it's not letting me go forward. So so that makes me happy that they're engaging with that and that they actually are reaching out to us. So far, I mean, we are behind in recruitment for many reasons. App development was a lot harder than I thought it was going to be. COVID still had us a little bit slow, but from what I'm seeing so far, people are interested in. They're coming to classes.
That's great. That's great. I mean, it makes so much sense, as you go into going into the community, and then creating a community of people that are aware of their past, of their situation with diabetes, and a shared experience. But then in an anonymous setting, so to speak, to be able to connect, and then to learn from people who know their situations, know where they're coming from, know their challenges, and so on, to then help and guide them to improve their glucose control, to understand diabetes, and take better care of themselves as they transition into the community. That's absolutely fascinating. It seems so relevant, so important to do.
Yes, we appreciate that ADA funded it, and we have the opportunity to be doing this because it is, I think, very necessary and relevant.
Very necessary, and a clear indication of ADA's interest in all health disparities related to diabetes, and ensuring that those people that need it most get the best care. And we're looking forward to it, because we know you're midway through your grant, and so there's still a long way to go and working on the app, and so but we're really excited, looking forward to seeing great data from that, and ultimately seeing how our returning citizens benefit and learn how better to take care of their diabetes as they enter back into the community.
Yeah.
It's been great chatting with you. I know we're running out of time, but it's been a great pleasure, Louise. Really a pleasure to chat with you, and all the best in your research. Thank you very
much, Dr. President. Take care. Bye-bye.